Okay, we are ready to go. I have been given the technology thumbs up. So, Excellencies, dignitaries, ministers, ladies and gentlemen, it is time for the last of our high-level sessions, the theme of which is health in the humanitarian context, communicable disease. I'm going to hand you over to the marvellous, the excellent Elise Laborde. If you don't remember her, she moderated that brilliant panel on migration flows. So please give her a very warm welcome. Elise, it's all yours.
Thanks, Juliet, and thanks once again to the King Salman Center. This has been an incredible 2 days. I've learned so much, and I just want to express my appreciation and respect for everybody here at the forum for the work that you do, helping them really the most needy populations around the world. Communicable diseases are a major cause of mortality and morbidity during humanitarian emergencies. Ensuring adequate shelter, water, sanitation, and food, and providing basic services are the most effective means of protecting the health affected by those emergencies. Protracted conflicts, weak health systems mean that countries may not be able to deliver basic health, nutritional, and social services. Now, the outbreak of the Ebola virus in the Democratic Republic of Congo, with a highly mobile population, a struggling health system, and a protracted conflict. Wild polio virus reemerged recently in Syria and northern Nigeria due to conflict, while Yemen has recently experienced the world's largest cholera outbreak. State fragility and dysfunctional health systems have led to multiple concurrent outbreaks during humanitarian crises in both Venezuela and Sudan. The number of high-threat infectious hazards continue to rise. Some of these are reemerging, and some of them are new. What disease will emerge next, or where, is not known. But countries undergoing humanitarian emergencies are at greater risk. Extensive environmental degradation and climate change create space for the emergence or reemergence of diseases that could become epidemic or pandemic threats. Also, the patterns of disease transmission have changed due to increased migration and international travel, with diseases now more commonly crossing borders. Displaced people are often cut out from accessing basic health services. Displacement often entails extreme stress, exposure to the elements, overcrowding, inadequate shelter, poor water and sanitation, all of which become more of a risk of communicable disease transmission and the threat of epidemics. Now, I'm learning new lingo here myself, working through the cluster, which we'll be discussing, shows that collective action is key, including multi-sectoral and multidisciplinary action. Partnerships enable the scale up to prevent, detect, respond, and recover from health emergencies. A systematic approach to the control of communicable disease is a key component of humanitarian response and is crucial to protect the health of affected populations. This requires cooperation among agencies working at local, national, and international levels, and collaboration among all sectors involved in the emergency response: health, food and nutrition, shelter, water, and sanitation. And we should note that the UN Sustainable Development Goals and health are all interrelated, but one of them is especially related to health, ensuring healthy lives and promoting well-being for all at all ages, directly targets specific maternal and child health improvements and communicable disease control and elimination. So there's a recognized need to ensure stability and a paradigm shift to work through an integrated collective approach for a sustainable communicable disease elimination framework. Now, you'll find that we have a smaller panel today. We have 4 wonderful panelists, but several, including your original moderator, had to pull out because of travel restrictions because of the coronavirus. Now, I promise you, this is not going to be a panel on just the coronavirus. I think we've had enough of those. But at the same time, this is a panel on communicable disease, and obviously we're going to mention it, but really in the context of a humanitarian setting and how this affects and how this can be transmitted through the world's neediest populations. You know, look, this affected our conference, our little conference. A lot of people had to pull out. That's really a first world problem, right? But I think it really drives home the point that if we're affected, imagine how the neediest populations of the world, the people in most fragile states are affected by the outbreak of communicable diseases of all stripes. So we'll keep them in our minds, and we'll also keep all the people that are worried about coronavirus, because it is top of mind. So we'll discuss it. We won't obsess over it. We won't focus on it. But we'll put it in the context of how we treat communicable diseases. And we have an excellent, really a first-rate panel to discuss this. I have to get my notes of my panelists. Dr. Ibrahima Sachefal is the World Health Organization's Assistant Director General for Emergency Response. He will be joining us for keynote remarks. We'll also be joined by Mark Bryson Richardson, Director for Middle East and North Africa of the United Kingdom. Dr. Ki Liu, Chief Operating Officer at International Medical Corps. And Ambassador Carl Skau, Head of Department for Conflict and Humanitarian Affairs in the Ministry for Foreign Affairs of Sweden. So the panelists will take their seats, and Dr. Fall, the floor is yours.
Thank you for this great opportunity to interact and communicate with this great audience about communicable diseases in the context of humanitarian crisis. I think talking about communicable diseases in an already complex humanitarian situation is adding complexity to an already complex situation. And because of the risk, not only for health and for the family, but the social and economic disruption we can have when we have an epidemic in the context of humanitarian crisis. I have spent most of last year dealing with Ebola outbreak in the Democratic Republic of Congo in the context of insecurity, in the context of broken trust between the population and the central government, and where armed groups are threatening the population on a daily basis. And coming to respond to an outbreak in this context is even more challenging than anything else. But it's important, I think, to remind ourselves about the context, because we are talking about humanitarian situation in general. The scale of complexity of humanitarian crisis is increasing over the year with interaction among many factors, including economic, environmental, political, security, and social factors. So that makes it difficult to provide essential health services to populations that are already vulnerable. And we are seeing more and more humanitarian crises directly related to or caused by armed conflict, and where we are seeing a more important prevalence of communicable diseases. Up to 70% of all communicable disease outbreaks are happening in fragile settings. So it's really important to keep it in mind while talking about prevention and responding to outbreaks and emergencies. And these populations are highly vulnerable with very limited access to health services and often experiencing the worst outcome of health services. Simple things like infection prevention and control are lacking both in the community but also in the health system. That's why you can see most of the time health workers being the first one even to be infected because they are operating in a very poor setting. And you found health facility being the amplifier of this outbreak, like what we have seen in DR Congo, where more than 200 health workers contracted the disease, Ebola disease. So to respond in a such complex, fragile, and rapidly changing setting, we have a number of challenges, both for local, regional, and international responders. So it's really important to put in place an efficient system for information collection and management for rapid decision-making, and also to have a sustainable supply chain management when you have to send supply to, through thousands of kilometers in the forest with very difficult access, when you need plane, helicopters, and truck to access to the population. We also need to make sure that we can use the local capacity to increase the health workforce and be able to address the most difficult needs. So in emergencies, there is no one organization or institution that can respond to all the needs identified. That's why it is important to really put a clear, comprehensive coordination mechanism, putting the country leadership first and all partners working together to strengthen that leadership. That's why for WHO, since the West Africa Ebola outbreak, through the reform, we are using the incident management system where we provide a platform for more cooperation with national government, but also with all partners based on the expertise and specific competitive advantage. So how this outbreak and unmet health needs disproportionately affect the most vulnerable countries and population. It's important to remind that 2 billion people live in countries with setting affecting fragility, conflict, and violence, and at least half of the world population will be living in such setting by 2030. So this environment has the highest rate of child and maternal mortality, food insecurity, malnutrition, and the lowest immunization rates. We have seen measles outbreak, yellow fever outbreak happening in, humanitarian situation where we have a vaccine for prevention. But if you don't have the system in place, if you have low immunization coverage with a cohort of population not immunized, it's really important to know that the risk is high. It's a matter of risk and vulnerability. The risk in terms of population susceptibility, but vulnerability in terms of capacity to detect, to prevent, and to respond to those kind of situations. Because
Dr. Fall, I'm going to ask you to hold. Excuse me, everybody. Can we please keep it down in the back? Can we close the doors? Dr. Fall is extremely busy and is giving his precious time away from dealing with communicable diseases to address this conference. So if we could give him the respect of if you'd like to talk, just please step outside. Otherwise, let's keep the room quiet. Thank you for your understanding. Please continue.
Thank you. So it's important also to really recognize that these challenges are compounded by lack of trust in public institutions and the presence of multiple, often competing national and regional authorities. For this reason, it's really important to prioritize community engagement and ownership. We have seen some situation in the Lake Chad Basin with the polio campaign, where the population accepted the responder because they were not identified as being part of one side or another. So this humanitarian principle is extremely important. In the opposite, in the Democratic Republic of Congo, it was very challenging to get the community engagement because when they see responders coming together with the government, for them, it was really a reason for mistrust because they have been abandoned by the government for many years, exposed to armed groups, and nobody was there even to fulfill their basic needs in terms of access to water, sanitation, and schooling. So coming to tell them I'm here because of Ebola, and they don't know Ebola, was extremely difficult. It took months and months to get the trust from the community and to convince them to work to protect the population. In the meantime, they have already lost many people because of Ebola. And so it's really important for humanitarian development actors to ensure coherent long-term planning, not only to respond to emergencies, but also for preparedness, prevention, and also for recovery and resilience building, because we need to really do what we call evidence-based preparedness, because we know where we have the risk, where we have the ecological niche for specific infectious disease. So it's important taking the evidence from the risk and the vulnerability to be able to build capacity for preparedness and for community engagement to also work before we have the outbreak. Because if you wait for the outbreak to happen to go to talk to the community, it's already too late. And we need to strengthen the health system, of course, by providing essential health services. But where we don't have, the right information system, WHO is working with government and many partners to have what we call the early warning and responding system, where we can have a more adapted information system, to specific context to be able to detect early enough to prevent and respond to this outbreak. So having this reliable source of information, as we have seen in South Sudan, in Somalia, is really crucial for early detection of outbreak. So in terms of action, I think it's really important for partners to work in a very coherent manner at country level. It will start, as I said earlier, by preparedness, working together to reinforce the health system, to make it more resilient and responsive to crisis. But it's so important taking into account the international health regulation, core capacity setting, and using the joint external evaluation to see where we have gaps in terms of detection, prevention, and rapid response to outbreak. And we don't need to wait for an outbreak to happen to start doing this. And defining an essential package of health services in fragile contexts is also crucial. This includes mapping of available services and partners to see exactly where we should prioritize our intervention. And that's why we work with partners to implement what we call the HERAMS, Health Resources and Service Availability Monitoring System, where we can identify priorities for action and also prioritize the financing for impact. And so at country level, when the outbreaks start, it's really important to act in a coherent manner, using what we call the strategic response plan, one implementation plan, one monitoring system with some critical key performance indicators. Because most of the time, when you work in a humanitarian setting, you have some medium to long-term objective. But when you have to stop a highly dangerous pathogen like Ebola, you need some short-term key performance indicator in terms of stopping the transmission, in terms of contact tracing, in terms of case management to reduce the case fatality rate. So coordination between all these actors, the health cluster, making sure that we use the humanitarian platform to provide all the essential health services, at the same time providing the specific services you need to stop the outbreak is really important. And we work with government to set up this platform and build the capacity for leadership and coordination to make sure that all actors are working together. So at regional level and global level, it's critically important to really strengthen multi-sectoral coordination mechanism to undertake joint analysis and planning and risk analysis and planning, need assessment, also having a joint monitoring platform to make sure that we provide the best quality of support and care for the population in need. Information sharing throughout the humanitarian platform and sharing information in real time with all stakeholders, making sure that we use all coordination mechanisms is crucial, like the UN crisis management system and using the competitive advantage of all agencies and partners. That's why for some high-impact diseases like yellow fever, cholera, we have some global mechanism to facilitate access to vaccine, access to technical support, and we also use what we call the GONS, the Global Outbreak Alert and Response Mechanism, where we can mobilize specific expertise from hundreds of institutions. So we need to really also work more in terms of more predictable financing, not just waiting for an outbreak to happen to start mobilizing resources. That's why, as part of the WHO reform, it was important to have the contingency fund for emergencies that allow us within 24 hours to start deploying people, even to respond to the COVID-19 outbreak. We started using the contingency fund for emergencies to deploy teams at regional level to countries to start working, building capacity for emergencies. So to conclude, I think it's really important to take into account all the determinants, not only in the health sector, but also outside the health sector, to make sure that we have comprehensive approach for prevention, preparedness, but also for response. Being ready for response needs also simulation exercise based on the risk we know already in various countries. So joint accountability and working very closely with the communities before the outbreak happens is crucial for success. Thank you.
Thank you, Dr. Fall. And before we were getting together, I sat with Dr. Fall, and he showed me on his phone a map of the world where he's dealing with outbreaks around the world as the World Health Organization's emergency response coordinator. What would Dr. Fall, were there like 200 different kind of outbreaks around the world? That just shows you how wonderful it is for him to have us today. In fact, World Health Organization has a working room here in the hotel where they're working on the coronavirus in between having bilateral meetings, speaking to the conference. And so the work that they do is so critical. And I just want to, again, on behalf of everybody here, express the appreciation for the World Health Organization's critical efforts. And I think he really, Dr. Fall, set the scene for the challenges and, the idea of dealing of a whole, in the United States we call it a whole of government approach, but here we call it a cluster, which is making sure that all of the humanitarian organizations, whether it's dealing with food, shelter, water, sanitation, all together for really a comprehensive approach. So Carl, why don't you start where Dr. Fall left off on what do you see as the key operational challenges to managing disease outbreaks in humanitarian settings and some of the key solutions that you think are necessary?
Well, thank you. And first of all, thanks for inviting me to this panel and for a very impressive meeting throughout. I just wanted to make two maybe general points also before getting into the question you said about the response. And that's first that outbreaks, there are two dimensions to outbreaks in an emergency. One is, of course, that it's having an impact on the population, and that's, first and foremost our concern. But secondly, also that it puts a lot of strain on the humanitarian operation in itself. I mean, if you have a cholera outbreak in a refugee camp, that is a nightmare for the humanitarian operations. I think it's an important dimension to reflect on, that it's first and foremost, of course, an issue for the population, but it's also a challenge for the humanitarian response, trying to deal with the broader humanitarian crisis. The second is that outbreaks in these contexts are unavoidable. I mean, it's always going to happen. We're not going to be able to do away with them completely. But I think that what's important is that the impact of the outbreaks when they happen can vary and depend on whether there is capacity and preparedness in place. And here there are important lessons learned that needs to be brought forward and put in place. And that brings me to the response. I think from our perspective, there's two things we focus on. And it's really, you can summarize it in investing in the system. The first is that we put money up front so that the system has the money already in its bank. We do that through supporting the UN agencies with core contributions that are flexible and that can be used in a way over the year where it's needed the most. We also provide money to what's called the Central Emergency Relief Fund, which is coordinated by Mark Lowcock, who was here yesterday, and which is also a flexible fund that can be used for immediate emergencies up front. And so, as a donor, we invest early, and we do that in a flexible manner so that the system itself has the money and can act swiftly and flexibly where needed and when needed. The second is, and that's the design of the system, and you touched on that, the cluster system. I mean, all since the reform years of 2005, we have invested in the cluster system, which is really about having a clearer roles and responsibility in these theaters and to make sure that accountability is there. And of course, WHO has the lead on addressing disease and health in emergencies. And we've invested a lot in making sure that WHO also has then the capacity. Lots has been done since 2005, no doubt, but I think even more can be done in ensuring that there is also the needed capacity and competencies in the field from the WHO side. I think reflecting on the role of WHO as well, they have, as we've mentioned, a lead role in emergencies, but they also have this lead role in addressing epidemics and outbreaks in non-humanitarian contexts. And I think those two roles are clearly, they are separate, but they are clearly complementary. And I think more can be done to support the WHO in this leadership in both tracks, but also on how they complement and how they can work together. And that actually brings me to coronavirus, although I know that's not the focus. I think it's, we, for example, I mean, we strongly support WHO in their way of addressing the coronavirus now. We have, put additional millions of euros to WHO, mainly to support countries with weak health systems to be prepared should they be hit by the virus. But I think, it's important to remember here as well that so far, at least, coronavirus is not considered a humanitarian crisis. We're not funding this from a humanitarian window. And while the situation with the coronavirus is very grave and deserves all the attention and response that it gets now, we should not forget the diseases that in specific contexts kills way more people in humanitarian emergencies. These are outbreaks of cholera, of measles, and diseases such as HIV/AIDS and malaria as well. And so I think that while Corona deserves its attention, when it comes to humanitarian emergencies, attention must really be given to these diseases that are far more deadly and grave than Corona so far.
I think that's an important point, and we're going to obviously speak about Corona a little while, and I think what we're really talking about is the differences in transmission, and when we're talking about cholera, malaria, these type of diseases, this is where humanitarian work and dealing with all of these different areas key, like malnutrition, food insecurity, water sanitation. These are some of the kind of key challenges to managing an outbreak, I would think. Why don't you pick up where Carl was talking about and some of the key challenges to managing disease outbreaks in these humanitarian settings.
Thanks for the question, please. And I'd also like to thank our organizers for the conference and this panel in particular. It's extremely timely. I think that clearly the world is grappling right now with coronavirus, and as we heard from Dr. Tedros yesterday, there's still a lot of unknowns in terms of the disease and how to manage it. But I think there's one thing that we can guarantee, that is we're responding to the coronavirus in a conflict setting where we don't have access to the population, where the health infrastructure has been decimated. It's going to be exponentially more challenging. So with regard to challenges, we can think of both external and internal factors that will challenge the ability for humanitarian organizations to be able to respond effectively to disease outbreaks in conflict settings. The International Medical Corps is a frontline humanitarian organization, and we operate in very complex settings where the interplay between conflict and epidemics is an unfortunate reality. We can think of conflict as public health in reverse, where all the safeguards are limited or non-existent for the affected community. And as you pointed out, Elise, that's why we have polio, right, in Syria, the cholera outbreak in Yemen, or the Ebola outbreak in the Democratic Republic of Congo, which I'll focus on a little bit just to explore and discuss these external and internal factors. August of 2018, the DRC declared their 10th outbreak of Ebola. And with the number of confirmed cases now surpassing 3,000, it is the second largest Ebola epidemic on record. And the outbreak is, the epicenter of the outbreak is in the city of Beni, which is in the eastern portion of the Democratic Republic of Congo, which for decades has endured violence and armed conflict. The result is we have 1 million internally displaced persons. We have a chronic failure to protect the civilian population. We have a decimated health infrastructure. And it's against this backdrop that the government of the DRC, international stakeholders like WHO, International Medical Corps, MSF, ALIMA, and others are trying to fight the Ebola. And, you know, Ebola response requires a multifaceted control measures. It requires early detection, the isolation of patients, specialized medical care, vaccinations, tracing of contacts. All of this assumes that we have access to the population. It assumes that there's the free movement and security of healthcare workers, cooperation from the population itself. And all of these measures are challenged by both external and internal factors. So external factors include the violence and the armed conflict. 2 weeks ago, the Ugandan rebel groups that they based their operations in and around Beni moved into North Kivu and attacked the cities of Mangina and Makeke, where we have our Ebola treatment center. As a result of the attacks 2 weeks ago, almost 90% of the population moved towards security into the town of Beni, which actually left our Ebola treatment center as the largest, highest concentration of people within the conflict zone. We had to evacuate our patients, we evacuated our staff, and only this past week did we restart operations. So there's conflict that is an external factor. There's also environmental issues in the DRC, where, as I pointed out, after decades of neglect, the health infrastructure is decimated. When we started setting up our Ebola treatment center back in August and September 2018, we were also doing the assessment of the surrounding areas to stand up screening and referral units, right? And you would go into these clinics that have operating theaters, and they have no running water. There's no electricity. I mean, this is what we're dealing with, and even though this is the 10th Ebola outbreak in the DRC, it's the first time it's ever occurred in Eastern Congo. So awareness and understanding of the disease itself is also an issue that the community faced when we went in to try to be able to mitigate and to be able to respond effectively. Complementing external factors are internal factors, the way that humanitarian actors and organizations operate, how we set up our operations, how we engage with the community, what we program, affects how the community views us, the trust, the social capital that has been pointed out here. And it's a critical factor. The Harvard Humanitarian Institute has been collecting longitudinal data in Eastern Congo for years. And you looked at the data, and there has been decreasing trust within government institutions, with humanitarian workers. So at the onset of this outbreak, we rushed in. I mean, we had a very effective, robust response. The community set up our Ebola treatment centers. We engaged in surveillance and early detection and vaccinations, right? But from the mindset of the affected community after decades of neglect, this was probably not what they were looking for in terms of assistance. Maternal child health care, water sanitation, nutrition activities, livelihood. And therefore, there's an imbalance between what we were delivering in response to the Ebola outbreak and what actually the community needed and desired. And that mistrust, there was a very interesting quantitative study that was carried out in 2018 that linked, again, right, trust and social capital, and that showed that where there was higher levels of mistrust, the ability for compliance with Ebola control measures was not at the same level. So again, these internal factors really do exacerbate the external factors that we have with regard to conflict and within the environment. Now, I will end by saying that the humanitarian community over the years has developed very solid operational framework to deal with external factors. How we act in terms of being impartial, neutral, independent, right? This classical model of humanitarianism has been effective in terms of how we negotiate access. But with conflict occurring now at this rate where on average crises occur for more than 7 years, it puts international workers within the community. And therefore there's been an emergence of perhaps a separate operational mandate in terms of perhaps we can characterize that as resilience humanitarianism, where we put the community at the center and we elevate the voices of the affected community, not only to listen to them, but to make sure that they're driving the decisions that we're making and the types of programs that we're making. And I will say that this community learned in real time. Within 3 or 4 months, we did expand the type of response from our Ebola activities to include maternal child health care, to include water sanitation or wraparound strategy, which then really brought in the affected community to be part of the Ebola response. And I think that that has helped us to be able to be much more impactful and much more effective in terms of what we're doing in the Democratic Republic of Congo. So let me stop there.
Thank you. Ladies and gentlemen, I just want to one more time kindly ask you, the acoustics in this room are not great. In fact, they're pretty bad, and we'll have to correct that for next year. But I know you don't think your whispering carries, but it's really hard to hear up on the stage. And if you could give the panelists the respect, if you want to have a conversation, take it outside. This is very technical and complex information, and we want all our audience to be able to hear what they're saying. I really appreciate it. Thank you. Mark, why don't you pick up, talk about a little bit what Carl and Key were saying, and how can these multi-sectoral and multidisciplinary collaboration be strengthened when you're dealing with some of these, both internal and external factors? I mean, some of it is collaboration among sectors, some of it is collaboration with, the government and the local actors, and then you're dealing with all these kind of external factors which are beyond your control.
Elise, thank you very much. And once again, thanks to the King Salman Center for a fantastic couple of days. I mean, very much to pick up on what Carl and Dr. Key had said. I mean, firstly, definitely an emphasis has to be on investing the right way before outbreaks occur. And I think part of that is the pre-positioning that Carl referred to, whether that's pre-positioning funds and resources with WHO, with the UN Central Emergency Response Fund. But also I think it applies more broadly to our engagement thinking about immunization, and immunization is one of the sectors we should perhaps come back to. Thinking about our broader engagement in strengthening health systems around the world, and Dr. Key talked about some of the challenges we see where health systems don't have inherent capacity, running water, electricity in place. We can do all of that ahead of outbreaks to increase resilience. And then particularly in fragile and conflict-affected states, as many people have spoken about, we see these wider factors coming into bear. So alongside the health challenge, we have to think about addressing instability, addressing weaknesses in terms of resilience of basic services, and sometimes weaknesses and lack of capacity in infrastructure, technical expertise, administrative expertise, to simply respond at scale in the way that is required for these crises. And I think in terms of the internal coordination, that's what you're talking about amongst ourselves as the international community, the importance of the cluster system, the importance of backing the leadership of WHO, for which we're all very grateful, and making sure that we're acting as one and getting the most out of our engagements. But I think it's also important about the way we think about it. So you talked about the different sectors, health, nutrition, water sanitation, and I think it's important to bring those all together, but I think there's more in terms of how we respond. So we've seen that thinking about conflict sensitivity, designing that into our programs from the start of them is really important. Thinking about safeguarding, thinking about governance, exactly Dr. Key's points. How will communities respond to the government sometimes turning up in a scale that it hasn't been present in those areas for quite some time? This may be the first at-scale interaction that citizens have with their government. How do they respond to that? How do non-state actors respond to that happening in their areas? And at the same time, that conflict awareness means that different factors think about health facilities in different ways. We all take it for granted that those aren't a target, they shouldn't be targeted. That's not how everyone is approaching that in a conflict setting on the ground. So I think in addition to the sort of health and humanitarian advisors that we traditionally think about, we need to think about social development, governance, conflict, safeguarding advisors, and actually sort of expanding beyond the traditional health cluster to think about how all of these things come together and shape our response. And particularly for fragile and conflict-affected states, I think we've had a tendency to underestimate the complexity of engaging in those contexts. And we're currently doing some lesson learning from Eastern DRC that definitely brings that home to us in the context of the Ebola response that the rest of the panel mentioned. And crudely, that lesson learning in Eastern DRC for me boils down to the fact we did quite well collectively, working together through this coordination to make sure we made progress in the kind of research, developing vaccines and the tools that we needed on the ground. But frankly, we didn't make the progress we needed to roll out those tools on the ground. The implementation, the support that was needed to actually deliver that was perhaps more challenging and lacking for us. And that ability to engage across those different disciplines, to think about community ownership, community buy-in, and to bring people together in a complex security setting, I think that's probably one of our big challenges coming up.
Thanks, Mark. Dr. Fall, one of the things that is becoming increasingly clear is that climate and environmental factors, drought, floods, insects that are spreading disease are affecting not only land management, and which leads to food insecurity, but is affecting the spread of communicable diseases. Talk a little bit about how climate is going to affect disease, and particularly in these humanitarian settings where this could actually, we were talking earlier, that this could expand the areas of transmission.
Thank you very much. I think it's really important for everybody to understand the impact of climate change in communicable diseases. We have a number of, epidemic-prone diseases we call vector-borne diseases transmitted by insects and mainly mosquitoes. We can talk about yellow fever, we can talk about malaria, we can talk about dengue, chikungunya, and many other diseases. So it's really important to see that the map of this vector-borne disease is expanding because of, climate change. If you look at some areas like even in, Northeast DRC, where you have the highland areas where malaria was not so prevalent, we had a malaria outbreak in the context of Ebola outbreak, and it was very challenging for the differential diagnostic and what to do with suspected cases. We had to organize a specific malaria response to make sure that we can prevent another communal transmission. For example, children going to the health facilities because of malaria, but getting Ebola because of the poor, infection prevention and control condition. And it means that in areas where we are not seeing malaria transmission or yellow fever transmission or dengue, we can see now more transmission for these diseases. So we need to anticipate in terms of risk mapping and prevention. And it will be really important to see where we are seeing an increased number of displaced population with no immunity moving to areas where they can also be affected by all these vector-borne diseases. and to make sure that we can prevent, big outbreak. At the same time, where we have flooding, like in Mozambique, Zimbabwe, Zambia, last year, we are likely to have cholera outbreak. Having strong global mechanism like the ICG, interagency coordination mechanism for access to vaccine, for cholera, meningitis, yellow fever is extremely important. And we need to invest more in this mechanism because most of the time we are very constrained in terms of availability of vaccine to respond to multiple outbreaks in many countries.
Thanks, Dr. Fall. Carl, also, over the last few years, we've been talking about the SDGs and how all of them are interrelated. The third one in terms of ensuring healthy lives and promoting well-being for all directly targets, health improvements. How do you use the SDGs as, a tool and an instrument to support collaboration approaches for communicable disease elimination framework to ensure sustainability and adaptation? Because when I'm looking at these SDGs, it's about eliminating poverty, eliminating hunger, clean water and sanitation. I mean, so many of these are all interrelated. You would think that if you're fulfilling these SDGs, you're going to really mitigate the risk of outbreaks and you can have early detection.
Yes. No, but I think that's the short answer. The SDGs is really the framework also for prevention when it comes to emergencies more broadly and conflict and what have you. I mean, we have now entered what the Secretary General of the United Nations called a decade of action. We have 10 more years to go, and we really need to make use of this framework because it's a unique framework. It's comprehensive, as you said, it's integrated, but it's also agreed by all member states of the United Nations. So it is really the one legitimate framework we have to push forward on all of these agendas. All of us have signed up to this, both as donors, but also as member states and recipients of cooperation. And I think what's unique with SDGs is that it's not this old classic donor-recipient. It's recognizing that we're all one integrated global world and that we all need to partner really to deliver on these. So I think, as I said, the short answer is yes. I think the SDGs is really the framework for not only building a sustainable future, but also to prevent disease and disaster more broadly. I wanted to pick up what you said before also on some of the challenges and lessons learned. I think, just to reiterate what Keith said about the lack of access and the increasing challenges when it comes to respect of international humanitarian law. I mean, this is a trend that we've seen over the past 5, 10, maybe 15 years, that the respect for these principles are eroding. And this is posing a massive challenge to a humanitarian response system that is already under stress in terms of demands going through the roof and resources not following through. So this is an issue not only for the issue of health, but more broadly, that is of extreme concern. But I would say that what we've seen when it comes to health is that over the past few years, and particularly maybe in Syria, but also elsewhere, health centers have been attacked and deliberately attacked. And this is a trend that is of course outrageous and that deserves attention and needs a serious response. This was, by the way, something we worked on quite actively while we were on the Security Council 17-18, and that other members also continue to look at. One other challenge, which I kind of mentioned, I would say, is that when we look at humanitarian situations, we really need to stay focused on actual needs and be needs-based. And that includes of course, the issue of health. And as I said before, that we really look at where the actual causes of death is the most, and that we are not carried away by what are potentially global threats, or where we see that we have supply, if you will, in our response, but that we really remain needs driven. And in terms of your question on lessons learned, I think one thing that has not been touched upon here yet is that in the area of sexual reproductive health and rights, we have seen progress in terms of the response over the past few years. There has been some setback in terms of some donors and some countries, changing their approach and policy to this, but in terms of the response and the work on the ground, there has been progress. And what we see when this is done in a good way is that it has a massive multiplying impact in terms of a healthy population. And so I think this is an area that deserves attention and more investment, both by donors but also by the partners on the ground.
That's a great point, and that kind of goes into what we were talking about in the morning panel, about when you treat women, whether it's health, whether it's women's rights. I mean, the more you can treat women and the children, you're kind of building up the whole society. But you brought up something in terms of health centers being attacked, and that kind of goes directly into how we improve community engagement and risk communications, especially when there is a lack of trust in government authorities and the international community. And Key, I'm going to throw this to you, but I think now, we've all had a chance to speak. Let's get a free-flowing conversation, so anybody just chime in. I mean, one of the most famous examples, we were talking earlier, is how in Abbottabad, after one of the doctors was caught using vaccination to work with the U.S. in terms of trying to find Osama bin Laden. That was like a very public example of how that, affected trust. But we see that, whether it's, the World Health Organization, the UN, often humanitarian workers are targeted. And, and then there's also the idea of, migrant populations don't want to go to the authorities. They're afraid they're going to get arrested. They're afraid they're going to get deported. And how do you, they don't have access to reporting. They don't have access to information. How do you improve that community engagement when there's a lack of trust in government?
So I had mentioned previously, right, we have kind of the classical humanitarian model based upon humanitarian principles of neutrality, independence, and impartiality. And the resilience agenda, I don't think, is at odds with the classic humanitarian principles. I think it's adding perhaps operational means that allows us perhaps to have more access to be able to provide for the safety and security of our staff. So I'll use an example again, our Ebola treatment center, where about 6 months into operations, we were starting to get negative press coverage within a local newspaper from the youth groups that did not understand what we were doing, because they saw us coming into the community. We built our Ebola treatment center. We put the fences around them. They saw patients coming in, and they saw body bags going out. And as clinicians and focusing on the treatment and saving lives, right, community engagement is no longer, or can no longer be, an afterthought. It has to be part of our programs, and I have to stress this, because without that community acceptance, without that communication, right, we cannot operate. We were at risk of having our Ebola treatment center shut down by these youth groups. So it requires this added constant communications with the affected community to explain what we're doing, to be able to tie in that this is impacting them. They may not have a mother, a father, or a brother, or a sister that has come down with Ebola, but to explain that the transmission of Ebola and how it can impact upon them and why we're doing what we're doing. So community engagement really is something that has to be at the forefront of our humanitarian principles, of how we engage with communities. And, when I think back again in terms of impartiality, independence, neutrality, we had 150 years to kind of put this into practice. Community engagement right now is something we're talking about, but I'm not so sure that we have proven mechanisms, the feedback loops with the community. Are we collecting the data for the sake of collecting the data? Are we actually using this data in real time to be able to change the way that we are providing our assistance. We're doing it, but 2 or 3 months after the fact, perhaps it's too long. So there has to be a balance between kind of this rapid data assessment when we're starting up our programs, but in real time investing in the mechanisms so that we are truly providing care that is appropriate and that is needs and based and evidence driven.
Thanks, Dr. Fall.
Yeah, I think it's really important to understand the context of North Kivu, DRC. So we are operating, distance like 1,000 kilometers. Where when you talk about community engagement, it's not just one community. Every community is very specific sometimes, and you need to know them and to understand them, and they need to trust them. That's why, and also we have a lot of political manipulation from the opposition groups. For example, in December 2018, when the presidential election was cancelled in North Kivu, a lot of local politicians were telling to the population Ebola doesn't exist. They just wanted to exterminate the Nande group, the specific group in the North Kivu. And it was really important for us to decentralize our operation to the lowest health areas level, meaning that taking the risk to send our people to the most dangerous, to set up community platform where we interact with the communities to understand them and to accept their proposition, by identifying members of the community that should be part of the Ebola response. But before that, you need to educate also for them to exactly know what is Ebola and why it's important for them to be involved. Unfortunately, for some of the communities, only when they started seeing their close relative dying that they started trusting that Ebola does exist. And but we have made a lot of progress. That's why we were able to have impact in all these health areas. We are talking about more than 600 health areas and where we deploy teams. And most of the surveillance is performed now by the community. And we are investigating more than 4,000, alerts a week, to detect Ebola. So very challenging because of the mistrust. We have recorded more than 1,700 security incidents, and 60% of them are related to armed conflict and crimes. So we need to take this into account and making sure that the community leaders at the lowest level of the system are involved and are leading the operation there. Thank you.
I mean, there's a danger we all violently agree with each other on this. I mean, I think it relates to some of the points we brought up earlier about the connectivity between these issues. So, as Dr. Key was saying, the political economy, they need to respond rapidly to what's happening on the ground. That's not just a health response, that's informed by a broader understanding of conflict, of governance, of what's
Emergency preparedness, really.
Exactly, and this emphasis on collaboration and thinking about how communities perceive the international community in the response, again, is not health in isolation. It's about how they perceive their government, about how they perceive the international community as a whole. And we need to be approaching it in that mindset and willing to adapt as we learn more about how communities are perceiving us. But if I could perhaps also pick up on something Carl said around collaboration. I mean, I think particularly in the health space, this is an area where we can't pursue these activities in isolation. The outbreaks may be specific, but the threats are shared across all of us and generic, and that's where we need to pull our efforts. I don't particularly want to talk about COVID either, but to put it into context, one of the UK's priorities in the health sector is antimicrobial resistance and broader global health security. That kills around 700,000 people a year. By 2050, that will wipe $10 trillion off of global GDP and kill 10 million people a year if we don't make progress against it.
So it sounds like what you're saying is donors need to prioritize funding or allocating resources for a more coherent approach in terms of collective outcomes.
Absolutely, and very much behind that kind of risk-managed approach that Dr. Ibrahim was talking about in the local context, but across all the different health challenges, let's take a risk management approach as to which ones matter. We in the UK put in about £1.3 billion a year bilaterally into health systems, some of which is going on COVID this year, but a very small part of that is going on COVID. The rest is going on much bigger threats. And I think there's opportunities for us to collaborate through a series of mechanisms. One we'll be championing this year is the Global Vaccines Alliance. We're hosting the next replenishment event in London in the summer. But that's an example of where countries can come together, pool our resources, get economies of scales in purchasing vaccines and deploying them at a level that's simply not replicable at an individual country level. And we hope we'll see 300 million children immunized on the back of that and 7 million lives saved. And that's an example of just where that economy of scale and collective action is essential. Because if we do that on our own, we just simply can't achieve those kind of results in the international system.
Okay, I think we're going to get a little technical now. How are global strategies, and I'm going to just throw it out there and let's just pick it up as we want. How are global strategies for cholera, malaria, dengue, measles, yellow fever, and other diseases being implemented currently in this humanitarian context? I know Dr. Fall knows all the answers. You want to start there, and then we can have the rest of the panel pick up on how they're dealing with it.
Thank you. As I was saying, for some of the high-impact diseases like malaria, yellow fever, cholera, we have a global strategy and global partnership mechanism, and this is really important in terms of mapping the burden of diseases, making sure that we prioritize where investment should go to prevent diseases and also to take care of people who are sick. For malaria, we have the global malaria elimination strategy, and with the 10+1 initiative. When we say 10+1 is the 10 high burden countries in Africa plus India. So if you look at the 10 high burden countries, you have countries like DRC again, like Nigeria, like Ethiopia, also where you have this complex humanitarian setting, but where you also need to implement specific disease prevention and control program like malaria. And we have a number of partners, mainly the Global Fund, and some bilateral, like the US, UK, supporting this global elimination program. So what is important is really what we call stratification and risk analysis based on the level of transmission, the level of prevalence, to prioritize investment at local level. It should go at local level.
Show of hands here. Carl, Mark, Key, when you're looking to implement an operation in country, maybe there isn't an outbreak of disease, to what extent is emergency preparedness, prevention for these type of diseases, cholera, malaria, dengue, measles, top of mind? Mark.
So I mean, I'm not sure how I show a hand to that.
Yeah,
it's definitely top of mind. I mean, exactly as Dr. Bahima said, I mentioned the Global Vaccines Alliance, but similarly the Global
we're going to
Fund
talk about new technologies and vaccines.
Yeah, but the Global Fund for AIDS, malaria, tuberculosis, and neglected tropical diseases, I mean, this has to be in a coordinated approach to develop research, vaccines together. It's simply not possible to do it on an ad hoc, separate bilateral basis. So we have to pool our resources to get the effects we're looking for. And that doesn't mean we don't all have a role to play, but we have to play it together. Otherwise, we just can't get the economies of scale and the advancements we need to see.
I see Carl, I see you're nodding.
No, just to say, I mean, what I said before, that for us, it's not, we don't do this country by country. I mean, we invest in the system. We are...
Like a platform.
And a platform, I guess you can call it. I mean, all of these funds that have been mentioned here, Sweden is a top contributor, and so really that's what we believe in, to make sure that we strengthen the system and make sure there is flexible and fast money should crisis arise, and that the systems itself can deal with it, rather than we sitting in Stockholm choosing countries and modes of intervention. But I think when we're now, what I didn't mention before, because I focused so much on the emergency response, is of course that we are also engaged in the health sector in our development partnerships. And that is done also bilaterally on occasion. And here, of course, I think, just to underline what has been said, that what really needs to be done is to strengthen universal health coverage and to strengthen the national health systems and the local health systems. And in doing so, of course, which has been also discussed here, in building long-term partnerships with local communities so that trust is there and the preparedness is then there should emergencies arise. So while we jump straight into the emergency side of the coin, I think it's important to just have that said, that what is really important here is, of course, to invest in long-term in the national health systems and to support universal health coverage.
Key, I guess, that leads to, you know, a more predictable and more preventable humanitarian health action.
Yeah, I think just to get back to the measles, malaria, polio, right? I mean, these are treatable diseases. We know how to treat them. The issue here, as I pointed out here, is that in a conflict setting, right? It's like public health in reverse. The system isn't there, their preparedness isn't there. And an initiative that WHO is leading, I think, helps us in terms of being able to be quicker, be more mobilized, more systematic. So they are standing up emergency medical teams, they're verifying international teams to ensure that when there's a crisis, that if a team is going to mobilize, that the local Ministry of Health understands and knows who's coming in, and we know that they have capacity. So International Medical Corps is currently going through the verification process, and it's helped us. It's helped us identify our systems to see where our gaps are. It requires us to be able to have surge capacity, not only in terms of personnel, but equipment and medicine supplies, and we sign on to the fact that if we're called to respond, we will be on the ground within 72 hours to start scaling up activities. So there's innovation that's taking place, and I also want to tie in a comment to the panel earlier today around evidence. You know, when we think about evidence and we think about Ebola, think about this. This is the first time in the DRC that we're fighting or managing an Ebola outbreak in a conflict setting. So as pointed out here, the conflict, there's been armed and targeted attacks against Ebola workers. We've lost lives. It has caused us to be able to suspend activities. But in the midst of all of these external factors, the government has engaged in a clinical trial that the International Medical Corps has been part of, the PALM trial. And for the first time in history in terms of battling Ebola, we now have 2 therapies in a clinical trial that have been proven effective. So even in the midst, right, of a conflict of dealing with an Ebola outbreak, there's innovation that's taking place that is allowing us now clear evidence as to something that will work and help us in terms of mitigating and respond to a future outbreak. So definitely there are things happening that we can look towards as positive influences that hopefully for the next outbreak will allow us to be quicker, timelier, and be more effective in our response.
Okay, warning, coronavirus is going to come up soon. Dr. Fall, picking up on that, what efforts, there are specific strategies to deal with infectious hazards like cholera, malaria, dengue, we've talked about polio, yellow fever, and the recent outbreaks, as we've been talking about, have driven innovation with the development of new diagnostics, vaccines, and therapeutics, but there are other high-threat pathogens for which there are no medical countermeasures, the coronavirus, and we'll talk about that a little in more detail. But what efforts are being made to accelerate the development and rollout of new diagnostics, vaccines, and therapeutics for priority diseases?
Thank you. 2 years ago, the WHO emergency program started a research and development program, the R&D blueprint, where we identify prior to disease, around 10 diseases, where we need to work with our reference centers, with experts, with private sector. We have more than 50 institutions working with us, for vaccine development, for therapeutics, a number of diseases like most of the viral hemorrhagic diseases like Ebola, Marburg, Cayman, Congo, Lassa fever are part of this blueprint. We had also the MERS-CoV, the SARS, And we are using this platform now for the COVID-19.
Right.
If we didn't invest 2 years ago, with a lot of support from DFID, actually, if we didn't invest in R&D blueprint, we will not be in a position to quickly bring together all experts working on the COVID-19.
That's an important point. I just want to repeat what he said, that the platforms they're using to look at the coronavirus were used in MERS and others. So it's good that you had that platform in place.
In fact, Dr. Lu was talking about the therapeutics in DRC for Ebola, the vaccine, the same. We use the same R&D blueprint platform to accelerate the development of the vaccines against Ebola and the therapeutics. And now, with this platform, we are having 3 teleconferences a week with experts around the world for vaccine and for therapeutics against the coronavirus. And we have had a meeting in Geneva early in February, bringing together experts physically, but also people from China and other countries who couldn't travel or virtually connected to contribute to the priority identification for research and development.
Mm-hmm. Okay, so here it comes, folks. I think one of the, yesterday there was a lot of discussion in the first panel about coronavirus, but I think it was talked about in more of a political context, whereas I think we didn't have a real opportunity, which is unfortunate, to talk about the virus itself. Talk to us a little bit, Dr. Fall, about the differences in transmission, okay, between a cholera and Ebola and a COVID, because you know, all these things we've been talking about, whether it's SDGs or climate or such, like it seems as if diseases like cholera and Ebola are more, you know, you can mitigate the risk. But it seems with COVID, it's a little bit difficult.
We have many groups of type of disease depending on the mean of transmission most of the time. When we talk about waterborne diseases, for example, we have cholera, typhoid fever, hepatitis E. And these type of outbreak happen almost simultaneously at the same place because people don't have access to safe water. The level of hygiene is very bad. So by drinking unsafe water,
drinking contaminated water
or food, you can contact, you know, this type of diseases. So when people are educated and provided with a means to prevent this type of disease, you can have an impact. Unfortunately, sometimes we are obliged to have some emergency response using the OCVs, oral cholera vaccine, to respond to this type of outbreak. We have had simultaneously in the Lake Chad basin, you know, outbreak of hepatitis E, cholera in very vulnerable population. It was very challenging and with huge impact on pregnant women. We really need to invest more to prevent them. So when you talk about other diseases like vector-borne diseases, this is transmitted by mosquitoes. But if you wait until the population of mosquito is really active, it's also difficult to start preventing them. Investing on environment management, also on some specific intervention depending on the type of mosquito for vector control is important. Now, coming to diseases like the coronavirus, where the transmission is through droplet, you need to be in a close contact with...
It's not bodily fluids, it's breathing.
So you need to be in close contact with the person who is sick. We know that there were reports of people without symptoms who transmitted the disease, but they were starting the disease with no symptoms at that stage. But the transmission is mainly driven by people who are symptomatic. So it's really important to keep, you know, a distance between people to make sure that we have basic hygiene conditions like hand washing but it's so important to prioritize protection for health workers because they are the most exposed. They need to have the required personal protective equipment. And for people who are sick also to use the mask we require and everything we need to isolate people, but also to be able to quickly detect cases by close contact monitoring. So for Ebola, it's different because you know, the transmission is through also close contact, but through body fluids, and so on. So it's mainly family cluster transmission, and that's why educating the population for community surveillance and rapid detection isolation is crucial for impact. And I was mentioning the number of community alerts we are getting in DRC, and to investigate them and to be able to detect early enough and treat cases, because now we have treatment. We have the vaccine, we can prevent more, we'll vaccinate around cases, but also we have the chance to save life when people go early enough to the treatment center.
Okay, I want to put Corona now in a humanitarian setting. And guys, jump in here. I know we're, at least 12 million refugees and IDPs are living between Syria, Iraq, Lebanon, and Turkey. Countries linked to Iran by travel. We're not talking about political or sanctions or anything. We're talking about the movement of people. Migration routes, shared borders, a lot of them porous. Iran is hosting 1 million refugees from Afghanistan, and hopefully, God willing, the peace process will go smoothly, and a lot of them will return home. So how can medical facilities in conflict zones cope with COVID and contain and stop the spread when people are coming in, people are going out? There's not a lot of reporting in these camps. I think it's fair to say that refugees are missing from this equation right now. I mean, I know we're on this panel thinking of it, but we're hearing very little public discussion about how it's impacting refugees, while a cruise liner with tourists, got more press and policy attention, through the international community. We've talked about how cholera and others are transmitted through water and food, but we're talking with COVID about rapid detection and isolation. How it seems like the idea of migrants and moving populations, that's totally antithetical to how you mitigate the spread.
So this is an additional challenge and even more complex. We have seen that even wealthy tourists are being affected by the coronavirus because they travel to high-risk areas. But we have seen also that all countries are at risk, because this last Friday, we upgraded our risk assessment in WHO to very high everywhere in the world. And when you have migrant population, first, we don't know before they move, the level of exposure to the coronavirus, because we don't have the health services with them to be able to assess them. When they move also to areas where they can be exposed to additional risk, it's very challenging because you don't have the surveillance system in place, you don't have the health services to offer to them. So this is a very challenging situation, and we need to make sure that when countries prepare for their populations, they take into account this specific population by providing, what they need in terms of human rights and access to health services.
Key, Mr. Sita, the Director of Health and the World Health Organization's Special Representative at UNRWA, said that, he's worried that, 5.5 million Palestinians are at risk. And that takes us directly back to the trust issue, that they're not trusting local authorities to be able to get that access, trust the reporting, trust what they should do. I mean, how do you break that cycle before you have an outbreak that you can't contain, that spreads?
I mean, I guess part of this, the communication and ensuring that those voices are factored in and are driving how we program and how we make decisions. And this is an appeal here. There's a lot of donors in the room, right? We have DFID and OFDA, right, and others in the room here. Is to build in that flexibility. And one of the things I would point out here is that as the humanitarian system has become more professionalized, and we talked about the cluster system, their specialization, right? Part of that movement of professionalism and systemizing things creates, in a way, a negative inflexibility into the system. So if we're dealing with an outbreak in terms of coronavirus here, there are agencies that are on the ground that are in the affected community. They may be programming nutrition, they may be working on gender-based violence, they may be in the shelter sector, but they may have the capacity to reprogram those funds in real time to be able to deal with the outbreak. So it's using what is available, and it's not always international actors, it's also going to local organizations, local governments, and ensuring that they have the resources needed. So that trust factor, is built up over time. And one of the, I guess it's a long way of answering your question, is that use the organizations that are there, that have the trust of the community, and make sure that there's enough flexibility where if they have resources, they can reprogram that. Or if they don't, plus them up, because it's better than bringing in another agency that's going to require 3 or 4 months in order to stand up their operations, get their people in, get their resources in, get the warehouse, get the logistics in place. Use what's there. I mean, it's first responder, it's local responders.
Carl, you talked a little bit about this earlier, about the need to kind of give immediate resources. Do you think that what Keith said, that organizations are nimble enough to be able to kind of reprogram, whether it's people, resources, or funding?
No, because not enough donors are providing core support. The trend is rather the contrary. I mean, in 2015, there was a big meeting in Istanbul on humanitarian affairs where everyone agreed on what was called then the Grand Bargain, where donors would provide more flexible, predictable funding in return for a more coordinated and effective system. I mean, that's a simplification of what was quite a complex deal. But we have not seen enough progress on there. On the contrary, I think over the past couple of years, except for a few donors, many go in the other direction of more earmarking and more projectification of their interventions. And so I think that this needs to be, this needs to be brought back to the attention. We need to provide incentives and the trust needed for donors to go in the direction of more unearmarked and more flexible funding, more predictable funding. I mean, DFID is exemplary in this. Sweden has also done a good job in this regard. Others some are moving in the right directions, others are in the wrong direction. I think this needs to be discussed because it's only when organizations like WHO, NGOs, but this is broader, WFP, I think it's the most critical here. It's only when these organizations have that kind of flexible funding base that they will be able to address quickly and be nimble and flexible, as you said. I think on Corona, though, I think it's important to remember here again that it's not considered a humanitarian emergency by the criteria established for humanitarian funding.
I'm going to stop you. I understand what you're saying, but I think what we're asking here is, could it become one? And does there a certain need to emergency preparedness to make sure that you're not, throwing money at and resources at the problem to stop it as opposed to preventing it?
Yeah, no, I think it's a good point that you're making because WHO is basically leading on both on emergencies and on addressing these non-humanitarian outbreaks like Corona. And I think there is discussion to be had on how they actually relate, how they overlap, and how capacity built for one can be used for the other. And maybe Dr. Fall can comment on that, but I think that's a discussion that we as strong supporters of both legs of WHO, for example, would want to have a serious discussion and see how we can contribute towards.
Mark, and then Dr. Fall.
I mean, just to pick up, I think absolutely, hopefully we do some of it, but I think there's a need for all of us to think about how we can do more kind of iterative, adaptive programming, enabling our partners to respond faster to events. But it does come back to this collaboration point and the risk management point.
Right.
The reason we're all backing WHO to lead on COVID-19 response is so that they can target those countries and settings that require it more. Those that are most at risk and most vulnerable need the support, and we rely on WHO to help us identify who those are and channel our support to them. So where we're providing assistance, DFID, for example, is providing assistance to WHO. We're going to deploy some technical experts to Brazzaville. That's because that's what the WHO have told us is the most important bit of the response. To pick up on the second part, absolutely, I think for all of these issues, we need to think about what it means in sort of conflict, fragile, emergency, and refugee contexts. But I think, and Dr. Ibrahim will correct me if I'm wrong, so far, thankfully, we haven't seen COVID-19 in an IDP camp or a refugee camp. I mean, when it gets there, it'll be really bad, but there's some element of isolation that is going to reduce the prospects of it getting there in the first place. But in the current context, and I thought Mark Lowcock spoke very well about this on the first day, I mean, the greatest threat to that Syrian refugee population coming out of Idlib is not COVID-19. It's some very real and unfortunately standard humanitarian responses, a lack of shelter, a lack of basic medical supplies, a lack of services. So we need to factor it into our response, and absolutely, if it gets there, it will be really bad.
Because as we said earlier, if you think about how much these people are suffering from lack of water, lack of sanitation, lack of shelter, to compound with an outbreak of whether it's COVID or any communicable disease, the suffering will just be, you think it's unimaginable now. It would become even worse. Dr. Fall.
You're absolutely right.
I love it when the panelists say you're absolutely right.
Now, I was mentioning the issue of risk and vulnerability. Is this really what we need to be able to identify those who are most at risk and living in a very fragile condition? That's why Dr. Tedros kept saying the impact in, weak health system will be huge if you have the COVID-19 in certain countries. And that's why also the strategic response plan we have developed for preparedness and response is targeting those vulnerable countries for more resources, more technical assistance. And we started early by deploying resources for diagnostic and sending teams to build capacity for isolation and so on. It's really important also to look at the way we are coordinating with OCHA under the UN Crisis Management Group. And OCHA is already releasing $15 million for the most vulnerable countries to make sure that they can start preparing and putting in place prevention system.
Yeah, I want to go back to the trust question, because there also needs to be trust between donors and their implementing partners. I go back in time a while ago. I was with the Office of Foreign Disaster Assistance, where many of you might remember the Good Humanitarian Donorship Initiative. So back in 05-06, I co-chaired that with counterparts within Sweden. And the whole purpose of the Good Humanitarian Donorship Initiative was how can donors streamline processes and procedures that allows partners to actually do the work. And we fast forward from that time to now, and I'm on the other side with the International Medical Corps, and I have to tell you, the amount of work that our staff, that we hire and you want us to put on the ground, that our clinicians, that our emergency responders, not to be doing paperwork. You want them in the field, you want them to be in the clinics, you want them saving lives. And yet it takes hours and weeks to be able to report back, to be able to guarantee that we're delivering the work. That is a cost in terms of how much resources flow to the beneficiaries. So it's an appeal again here in terms of the trust as well for implementing partners to allow us to be able to do the work as a partner. And one last appeal here is that I've also seen a shift between accountability. When we're operating in a Syria context or in Yemen, things will happen. It's a conflict, it's a complex emergency, things go wrong. And with the movement these days around compliance, unfortunately, a lot of that has been shifted to the implementing partner to take all the risk. If there's something that happens, the disallowance is on us.
And it's easier to take it out on them.
So please, again, I would appeal again for trust and partnership with your implementing partner. We are in this together.
That's a great point. I'm going to open it up in a minute, but I think this is a panel on communicable diseases, but Dr. Fall and I were talking earlier that we'd be remiss if we didn't talk about non-communicable diseases. And Dr. Sita, who was with UNRWA and unfortunately was unable to join us today because of
coronavirus restrictions, made a point that it's non-communicable diseases like diabetes, hypertension, cardiovascular, cancer, and respiratory conditions are by far the largest health burden to, Palestinian refugees, but also Dr. Fall and I were talking that, this is really people in these high-risk, fragile situations. They may escape cholera, but then they're going to die of diabetes or hypertension. So, Dr. Fall, talk about that a little bit.
I think this is a very important question because most of the time we are focusing on communicable diseases, but if you look at the double burden of communicable and non-communicable diseases, including in humanitarian setting, many people are dying from non-communicable diseases. I was WHO representative in Mali some years ago. When I just started, I realized that in the health clusters, they didn't accept an NGO that was called Santé Diabète because they were only working on diabetes. So I had to work hard to make them accept that diabetes should be part of the health cluster.
I would think that's one of the really bad things because these people don't have access to, low sugar foods or, their diet, like beggars can't be choosers here. They don't have access to exercise or any, kind of clean living.
In fact, when we did the assessment in terms of access even to insulin, they can stay months, the displaced population without access to insulin. And when we assess the availability of basic health services, the most affected area was really related to non-communicable diseases and maternal health. So we end up organizing some kind of mobile team with experts from the capital to the most remote area. I think it's really, really important when we talk about investment in the health cluster to take into account all types of risks. It's not about outbreak only, but we need to address non-communicable disease, including mental health. This is a big need in all humanitarian settings.
Yes or no, Carl? Do you think of that when you're...
Yeah, I just wanted to pick up on what was said about mental health. I think that's a huge issue in emergency context. The Dutch government has taken leadership in drawing attention to this and also mobilized more resources. It's something we support and commend because it's also something that has not been given due attention in the past, and it has a multiplying effect because if mothers are affected by mental health problems, that's something that is passed on to children and has implications for the broader coping mechanisms of the family. And there is also a stigma around this, which is not only for emergencies. I think that's something also in Sweden and other countries, but I think particularly in this context where the share of the population having these kinds of problems are so large, it's something that really deserves more attention.
Mark? Okay, I think we're going to open it up to the audience. I'd like you, when they bring a microphone around, we're going to bring the microphone to the front row here to Dr. Mahmoud Malik, who's the World Health Organization's representative in Somalia. His counterpart in Yemen said that the Yemen program compared to the program in Somalia is far bigger, but Somalia really punches above his weight. So Dr. Malik, talk to us about your experience in Somalia in terms of, containing outbreaks, managing health situations there, and talk about, he's also a communicable disease expert. So Dr. Malik, share with us some of your thoughts as we're closing our panel.
Thank you very much. I think what we need to do in settings like Somalia and other humanitarian contexts is to do things rightly, do things correctly, and be credible to our partners. Because unless we are transparent, I think we are always behind the curve. In the context of Somalia, in the last few years, we have managed, I think, massive outbreak of cholera, the measles, and also other communicable disease outbreaks. The key was for containing this outbreak or controlling the outbreak was to implement some evidence-based interventions. Because unless you follow the strategy that is working and that follows the best practices globally and that is contextualized on the situations, you will never be able to contain this outbreak. I think it is important to understand the context because we have talked about the mental health issues, NCD, non-communicable disease. If the context is different, then one size will not fit all. So you need to understand the burden of diseases in that context. What strategy will work well? And in humanitarian context, we also need to be sure that there is always a pressure from the donors, but you have to do things correctly. Maybe time is essence, but you have to also be sure that you have to do things correctly. And correctly means you put in place the right intervention and right strategy, making sure that intervention or strategy has the greatest and maximum public health benefit. So if you follow this strategy and if you are transparent, and one of the information that I want to pick up from there is to sharing the information. You need to monitor the health situations. You need to monitor the impact of our intervention on a regular basis, seeing whether your intervention is having an impact in controlling the outbreak. If not, you change the strategy, you change the interventions. Often we are ignoring these sort of simple common sense issues because then you are always behind the curve. So given, again, the context of Somalia, I would say that when you have a weak governance, the weak management capacity, there is an expectation that agencies like WHO and the other UN agencies should be proactive in managing the outbreak because we have seen that the outbreaks can cause health security threats. And this is the situation what we are seeing in coronavirus.
That's a great point about security.
So that is the important things, that there will be a cross-border spread of the diseases because there are neighboring countries are always guarding their border, and they will put their finger to you that you have not been able to contain this outbreak. So in order to achieve those things, I would say that during the peacetime, we need to build national institutions. And that's the only way forward that you can manage outbreaks effectively and efficiently during these wartime situations. So my appeal to the donor community would be to invest during the peacetime on building the national public health institutions.
That's a great point. Talk to us about the trust issue, because particularly in Somalia, you know, we've talked in kind of general terms about trust, but particularly in Somalia, you know, health workers are targeted.
Look, health workers have been targeted in some areas, not throughout the country. The reason is that you need to have the right messaging to the people, to the community at large, that health workers are not your enemies. They are here to serve you. They are here to serve the vulnerable populations. Again, I would like to highlight the fact and the word transparency. You have to be very transparent. You have to give the right messages at the right time to the community so that the trust is built. But this trust needs to be built during the peacetime, not during the wartime. So you need to have a system in place, a strategy in place to make sure that that community engagement, that community perception towards the healthcare workers is perfect or correct as much as possible. So that's the way we need to work together. And this is a collective responsibility, not only for the agencies like WHO and other UN agencies. All donors have to understand this is a collective responsibility.
Thanks, Dr. Malik. We'll open it up to questions. If you have a question, can you raise your hand and identify yourself? Thanks.
عمرو محمد مسحلي.
مساء الخير. الدكتور فيصل العواضي، وزارة الإعلام اليمنية. لدي بعض الأسئلة ربما بحكم عملي كصحفي، وهو أن أهم مصدر الآن من مصادر الأمراض بسبب الصراعات والحروب. فالسؤال هنا: ما مدى التنسيق بين منظمة الصحة العالمية وبعض المنظمات الدولية العاملة في هذا المجال، وأهمها منظمة الصليب الأحمر الدولية وأطباء بلا حدود؟ هل تترك منظمة الصحة العالمية لوحدها أم تستعين بهؤلاء وتتكامل الجهود؟ السؤال الثاني: ذكر المتحدثون أن من أسباب عدم القضاء على بعض الأمراض في كثير من الدول وخاصة الأمراض المستوطنة مثل الملاريا وغيرها يرجع إلى ضعف الأداء في المرافق الصحية. وهنا سؤال يعني سأطرحه عن حول شكوى قد لا تكون مسموعة ولكنها موجودة، وهو أن هناك احتكار لبعض المستويات العلمية التي لا نحصل عليها من الدول المتقدمة، حتى ولو ابتعثنا بعثات طلابية لا يحصلون على مستوى التعليمي في بعض المجالات. والسؤال هنا: هل تمتلك منظمة الصحة العالمية رؤية لعمل ميثاق أخلاقي في أن الحقيقة العلمية يجب أن يتساوى فيها الجميع؟ وسؤال أخير وهو
Yeah, I think we're going to have to cut it off at 2. Thank you. Dr. Fall. Dr. Fall, why don't you just answer about your coordinate? The question was, does the World Health Organization coordinate with other organizations? I think the talks on the panel suggest that you do, but maybe you could fill that in. And about sharing science, a good point. Thank you.
Thank you very much. In terms of coordination, I think it is important to know that when we have an outbreak, it's not only WHO working to respond to the outbreak. We have what we call the strategic response plan with a number of pillars. In this pillar, you have the specific health expertise, where you have WHO, you have some NGOs like Médecins Sans Frontières or Doctors Without Borders, like Alima, like your organization. I cannot miss you. And we have some even, bilateral contract for case management, for example, for Ebola in Congo with IMC and Alima. And in addition to that, we have a number of pillars like community engagement, where UNICEF is the lead. In the community engagement, we also have community engagement beyond the specific disease, where you have the World Bank, you have the OCHA, and all this. So WHO helped to strengthen coordination by national authorities and to make sure that we have the right plan, the right monitoring system, working with OCHA and other partners, but we never work alone to respond to emergencies. Is there an outbreak or disaster? We always make sure that this is done in partnership, not only at the country level, but also at global level. I mentioned the global outbreak alert and response mechanism, where we work with so many institutions around the world to be deployed. We have the emergency medical team as well. So it's really a partnership and coordination work. In terms of knowledge and science, I will just share one concrete example. Within the WHO emergency program, we have what we call the Open WHO. This is a free platform where we have a number of courses and modules accessible to everybody, everywhere in the world. We have a number of people working in poor countries, in the most remote districts, who are accessing these courses. Only for the COVID-19, we already have more than 40,000 people who registered to this course.
40,000 people.
Yeah, and this is very dynamic and interactive, because anytime we have a new, disease outbreak or priority, we work very quickly while developing guidelines also to update our platform for open access for learning. I think this is a concrete example on how we transfer knowledge as well. But we have other mechanisms, of course.
Thank you. Okay, sir, right here.
السلام عليكم. عمرو محمد مسحلي، مشرف النشاط ورائد البرامج في الحد الجنوبي بمنطقة جازان. أبغى أسأل عن الأمراض المعدية. ما هي الأسباب لهذه الأمراض؟ وهل فيه هناك أمراض يعني من صناعة البشر كحرب بيولوجية؟ بس شكرا.
Who wants to take that one? Man-made diseases. Dr. Fall, I think it's going to rely on you.
Okay, I think even before the new technologies, we have seen, in the past centuries, big outbreak of infectious diseases without necessary, the action of the man. So, but right now we all know about the risk of bioterrorism and so on. So when we talk about preparedness, we need to take into account both, natural outbreak, but also possible bioterrorism is important as part of the global health security, and every country preparedness for health security. We cannot ignore the possibility of bioterrorism using the pathogen we already know at some manipulated pathogen. This is important.
Good point. Do we have any more questions? Sir, I see you right there. I want to see if there's a woman first, since we have an all-male panel too. Let's go to this woman right here in the front, and then we'll go to you, sir.
First of all, welcome in Saudi Arabia. We open our hearts before we shake hands with you. And excuse me.
Just wash them first. Just kidding.
With respect and love and peace. And excuse me, I would like to speak Arabic, the mother language. أشكر كل الجهود المبذولة من مركز الملك سلمان للإغاثة. أحب بس أعرف بنفسي، أنا نورة الشعبان، نائب رئيس لجنة حقوق الإنسان والهيئات الرقابية ومكافحة الفساد في مجلس الشورى السعودي. كنت أتمنى أن يتم التنويه في بداية كل منتدى بجلسة نقاش محددة توضح ما هي نسبة ما تحقق من توصيات المنتدى السابق وما هي خطتنا الاستراتيجية القادمة. ما هي الأدوات الفاعلة التي توصلنا لإيجاد حلول عملية. 2. كنت أتمنى أن نستضيف في جلسة مخصصة لعدد من اللاجئين لعرض الصعوبات والعقبات والنجاحات كقصص واقعية لتكون قيمة مضافة للإنجازات الحقيقية التي توضح الجهود الحقيقية لمستقبل البشرية. ليكون هذا المنتدى المنصة التي توصل صوتهم الحقيقي للعالم. أنا شخصياً حبست دموعي عندما شاهدت معرض الفن الإنساني، والذي فعلاً كان يوصل الكثير من الرسائل اللي أتمنى بعد نهاية هذه الجلسة والتوصيات أنهم يزوروه، لأنه كان فعلاً رائع، يتحدث عن قيم كثيرة. أكرر شكري، نحن دائماً في المملكة العربية السعودية نستقبلكم بكل الحب وكل الاحترام والتقدير والسلام. وشكراً لإدارتك المتميزة. You were really amazing moderator. Thank you so much for the management of this session.
Thank you. Thank you very much. Carl, I'm going to throw it to you. Talk about, how have we done in the last year in terms of, we have goals every year in terms of what we want to achieve in terms of the humanitarian space. Talk about some of the progress in the last year and some of the challenges that you think need to be addressed in the year ahead. After you do that, I'll talk about specifically some of the recommendations World Health Organization.
Well, I think that, like Mark Lowcock said yesterday as well, there is recognition that the system is getting better, more effective, and more accountable in terms of delivering assistance, and that is increasing by the year. But at the same time, the challenges are also increasing, and the needs are increasing. So the gap between what can be addressed and the needs remain, if you will, if not increasing. So, but I think there needs to be this recognition that in terms of our preparedness, in terms of the effectiveness, in terms of the delivery of the system, there has been progress and there continues to be progress. Looking at country context, unfortunately, there isn't much good news out there. But maybe point to one context where I know also we have representatives, if not in the room at this forum, and that's Sudan, where we have seen important positive developments over the past year. And I think here it is very important now that the international system steps up and really support the Sudanese in this effort. It's an impressive transformation that is very much Sudanese-led and Sudanese-owned, but they have now reached a phase where the international community needs to step up. And this is both in terms of addressing humanitarian needs, which are actually increasing, and to ensure that this support is sustained in the humanitarian field, but even more importantly, of course, that the development assistance in a significant fashion can move in quickly in order to support this transition.
Sir, you want to raise your hand? I'm going to ask you to really keep it like a mini question because we have to close exactly at 4 so that we go to the recommendations. Can someone run a microphone over to this gentleman right here? Raise your hand, sir. Yep. Can we get a microphone? Shui, Shui.
As you said, it will be very short question. So I worked in several epidemics in Horn of Africa and Middle East and North African countries. And one of the worst point actually in all of these epidemics is to have a very weak surveillance system because of lack of good laboratories for like biosafety level 2 or 3 laboratories in our regions, and I mean in Horn of Africa particularly, and also Middle East and North Africa. So also the lack of diagnostic tools to for tropical diseases in particular. I don't know in the efforts for WHO. I know the whole university in the world so are developing this kind of tools. But what is the role of WHO and other UN institutions and other institutions to support this kind of essential tools to early diagnosis and early response and to minimize the epidemics outcome either as in casualties or or economy or politics.
Okay, thank you. Dr. Fall, you're in the hot seat.
Thank you. This is a very important point. Capacity in terms of lab diagnosis is a key component of the health security, but also of the overall health system. So we need really to bring together our investment in the general health system and what we need to do in terms of health security. If it is fragmented, it will be difficult to have all this capacity. And if you look at all the joint external evaluation of the international health regulation, you can see throughout Africa that the capacity to detect is weak. And just to give you an example, for yellow fever, if you go back 3 years ago, there was only one reference laboratory for the entire Africa in the Institute Pasteur of Dakar. And under this air strategy, eliminating yellow fever outbreak, we have a plan to have 6 reference laboratories. Now we have 2 additional in Uganda and another one in Cameroon. To just give you an example, even Nigeria, this big country, didn't have a reference laboratory for yellow fever, and we are investing a lot to build that capacity, not only for yellow fever, but for other diseases like Lassa in Nigeria. And I can say the same for other priority diseases. So we need to make sure that while we are investing in the health security, every investment on primary health care in the health system also prioritize the laboratory, but because our capacity to control outbreak depends on the timely detection and rapid response. If you are missing detection because you have to send sample, from one country to another, it's very difficult. When I was in Mali, we have to send sample for Ebola testing to Atlanta before we got the mobile laboratory. If you go to DRC, 2 years ago, we were sending sample to Atlanta as well. Right now, they have 12 mobile laboratories in provinces detecting, Ebola. We need to continue doing that. I think it's important to continue investing in the laboratory. Thank you.
Thank you, and thank you for your question. We're going to have to leave it there. I want to thank my panelists. Everyone here in the humanitarian space works so hard, but particularly the health professionals that are here and that are working on the coronavirus. As we said, you know, we've been affected in a small way by, unfortunately, some of our speakers and guests were unable to come. But the people on this stage, the people from the World Health Organization and other health organizations are leading the worldwide response, and we want to thank them. And it just shows how important the efforts of KS Relief are and how important they thought it was to come to you. So I want to thank all of my panelists, particularly Dr. Fall and the World Health Organization for what they're doing. Thank you. Thank you again to KS Relief. I just want to close by saying the World Health Organization has 2 recommendations that evidence indicates, and we'll be talking about them, but and we talked about this, the use of the SDGs to support a communicable disease elimination framework and sharing information. We talked about sharing the science. And now, you know, as we close the conference, they'll be talking about these fuller recommendations. Thank you all. Thank you very much.
And many thanks there to Elise Labotte. As ever, an excellent debate, very well moderated, with some intelligent, insightful comments from her panel. So, Excellencies, dignitaries, ministers, ladies and gentlemen, we have been together now for 2 days at the Riyadh International Humanitarian Forum, and we have discussed many subjects surrounding the world of humanitarian development. There are many challenges happening around us and which lie ahead in the future. But what has come out of the time spent together are a series of recommendations. These recommendations are a roadmap for the future to tackle those challenges head on. We're going to reveal what the details of those recommendations are. And I'm now going to hand the microphone and the stage to my colleague in the media, the Arabic media, of course, the distinguished television anchor for Al Arabiya Television, Mohammed Tomei. Please, the stage is yours.
شكرا جولييت بوستر. السيدات والسادة، يسرني الآن أن أعلن البيان الختامي لمنتدى الرياض الدولي الإنساني الثاني. أولاً، في مجال تعزيز الربط بين العمل الإنساني والتنموي، التوصية الأولى: التنفيذ الكامل لالتزامات قرار الجمعية العامة للأمم المتحدة 279 تقسيم 72 بشأن إعادة وضع نظام الأمم المتحدة الإنمائي، بما في ذلك تنفيذ اتفاق التمويل وإطار المساءلة الإدارية وإطار عمل الأمم المتحدة للتنمية المستدامة من أجل تعزيز التعاون بين التنمية الإنسانية والسلام والحد من احتياجات الناس والمخاطر على مدى عدة سنوات. التوصية الثانية: استمرار الدعوة إلى تعزيز التعاون بين الجهود التنموية والإنسانية والسلام للحد من الاحتياجات الإنسانية والمخاطر وأوجه الضعف على مدى عدة سنوات، بالاستناد إلى الميزة النسبية لمجموعة متنوعة من الجهات الفاعلة، ومن خلال نتائج جماعية واضحة وقابلة للقياس تسهم في تحقيق أهداف التنمية المستدامة وتستند إلى آليات المساءلة المعززة. التوصية الثالثة: استمرار تعزيز التعاون الإنساني والتنموي لتحقيق اتساق وكفاءة أكبر في العمل الإنساني والتنموي في الأزمات، والانتقال لتنمية مستدامة طويلة الأجل للحد من المخاطر وبناء القدرة على الصمود، وذلك من خلال اللجنة التوجيهية المشتركة بقيادة مكتب الأمم المتحدة لتنسيق الشؤون الإنسانية وبرنامج الأمم المتحدة الإنمائي. التوصية الرابعة: إنشاء قنوات تواصل فعالة بين المنظمات والهيئات والمجتمعات المشاركة في العمل الإنساني ونظرائهم من الجهات التنموية لضمان بذل جهود فعالة وموحدة للوصول إلى المستفيدين. ثانياً، في مجال الصحة في السياق الإنساني، التركيز على الأمراض المعدية. التوصية الخامسة: استخدام أهداف التنمية المستدامة أداة لدعم نهج تعاوني متكامل لوضع إطار مستدام للقضاء على الأمراض المعدية. التوصية السادسة: تبادل المعلومات الهامة المستمدة من أنظمة الإنذار المبكر لضمان التدخلات المبكرة ومكافحة الأمراض بطريقة أكثر فاعلية من جميع الجهات الفاعلة وأصحاب المصلحة. وفي مجال الهجرات الجماعية عبر البحار من إفريقيا إلى دول الخليج وأوروبا في الحالات الإنسانية، كان هناك التوصية السابعة: فهم أشمل لنطاق مشكلة الهجرة بما في ذلك الدوافع المختلفة والمترابطة والاتجاهات ونقاط الضعف ومراعاة الممارسات الإيجابية في بلدان المنشأ والعبور والمقصد، وذلك للتحكم بشكل أفضل في ديناميكية تدفقات الهجرة واسعة النطاق. التوصية الثامنة: الاستفادة من المناقشة في هذا المنتدى للمساهمة في تحقيق الميثاق العالمي للهجرة الآمنة والنظامية والمنتظمة GCM، وكذلك هدف التنمية المستدامة 10.7 لتيسير الهجرة وتنقل الأشخاص على نحو منظم وآمن ومنتظم ومتسم بالمسؤولية من خلال تنفيذ سياسات الهجرة المخطط لها التي تتسم بحسن الإدارة. في مجال المرأة والطفل وذوي الاحتياجات الخاصة في مناطق النزاع والكوارث وتحديات العمل الإنساني، جاءت التوصية التاسعة: الاستثمار المتزايد والدعم المتعدد لقطاعات الأطفال الصغار ومقدمي الرعاية في حالات الأزمات والنزوح، بما له من تأثير فوري ودائم على حماية حقوق الطفل والنهوض بها وإنشاء مجتمعات سلمية ومستقرة في المستقبل. التوصية العاشرة: الاستثمار في الطفولة المبكرة أمر ضروري لتحقيق اتفاقية حقوق الطفل والالتزامات المتعلقة باتفاقية حقوق الأشخاص ذوي الاحتياجات الخاصة، وكذلك تحقيق العديد من أهداف التنمية المستدامة. التوصية 11 والأخيرة: الاستثمار في تنفيذ وتطوير مشاريع التدخلات الإنسانية للأشخاص ذوي الإعاقة لضمان حيادية الاستجابة الإنسانية ومراعاة كرامة وحقوق جميع الأشخاص، لأنها تمكنهم من بناء قدراتهم وتساهم في دعمهم وحمايتهم وإدماجهم في مجتمعاتهم في مناطق الصراع والكوارث. منتدى الرياض الدولي الإنساني الثاني من مارس 2020. شكراً لكم، وأترك المجال الآن للزميلة جولييت فوستر لقراءة البيان باللغة الإنجليزية.
Thank you, Mohammed. This is the outcome statement in English from the second Riyadh International Humanitarian Forum. Humanitarian Development Nexus. Point 1. Fully implement commitments of the UN General Assembly Resolution 72/279 on the repositioning of the UN development system, including delivery of the funding compact, the management accountability framework, and the UN Sustainable Development Framework in order to strengthen humanitarian development peace collaboration and reduce people's needs, risks, and vulnerabilities over multiple years. Point 2. Continue to advocate for and strengthen humanitarian development peace collaboration in order to reduce people's needs, risks, and vulnerabilities over multiple years, based on the comparative advantage of a diverse range of actors and through clear and measurable collective outcomes which contribute to the SDGs and are based on strengthened accountability mechanisms. Point 3. Under the Joint Steering Committee led by OCHA and UNDP, continue to advance humanitarian and development collaboration to promote greater coherence and efficiency of humanitarian and development action in crises and transitions to long-term sustainable development and in reducing risks and vulnerabilities to building resilience. Point 4. Support strengthened and inclusive collaboration between humanitarian development and, where relevant, peace actors and communities to ensure the reduction of risks, vulnerability and overall levels of need of affected populations by working towards collective results. Health in humanitarian context focus on communicable diseases. Point 5. Use of the SDGs as an instrument to support integrated collaborative approaches for sustainable communicable disease elimination framework. Point 6. To share critical information generated through early warning systems to ensure early interventions and more effective disease control elimination by all actors and stakeholders. Large-scale migration flows from Africa across the seas to the Gulf states and Europe in humanitarian settings. Point 7. Create more understanding on the scope of the migration problem, including the different and interconnected drivers, trends and vulnerabilities, and to consider positive practices in countries of origin, transit and destination in order to better control the dynamic of large-scale migration flows. Point 8. Harness the discussion from this forum to contribute to the Global Compact for Safe, Orderly and Regular Migration, GCM, as well as the SDG 10.7 to facilitate orderly, safe and responsible migration and mobility of people, including through implementation of planned and well-managed migration policies. Women, children and people with disabilities in humanitarian crisis and the challenges of humanitarian action. Point 9. The increased investment and multi-sectoral support for young children and caregivers in crisis and displacement settings have immediate and lasting impact on protection and advancement of child rights and the creation of future peaceful and stable societies. Point 10. Investment in early childhood is imperative for the fulfillment of Convention on the Rights of the Child, CRC, the Convention on the Rights of Persons with Disabilities, CRPD, related obligations, as well as the attainment of multiple SDGs. Point 11. Investing in the implementation and development of humanitarian intervention projects for persons with disabilities to ensure the neutrality of the humanitarian response and observance of the dignity and rights of all persons as it empowers them, builds their capabilities, support, protect and integrate them with their societies in conflict and disaster areas. 2 days has produced a very powerful commitment, a pledge agreed by all of you here in this room. It is your roadmap for the future. You will face many challenges, but you know this. You will have the courage not to turn away, but to pursue what is right, to produce a better, responsible, kind, decent world. I wish you well on that journey. And as we reach the end of the 2020 Riyadh International Humanitarian Forum, one final reminder to show you what kindness, compassion achieves. Stay with us because there is a volunteer session. It starts in a few moments. You can hear what people on the front line do, the results that they achieve, and more important, why they do it, because they care. Compassion is never in short supply. I'd like to thank King Salman Relief, the United Nations agencies, and all of those who came here today, who put this extraordinary event together. Thank you so much for the hospitality and the kindness that you have shown me personally, but also for your wonderful work. It's a powerful statement and one that will never be forgotten. One final piece before I retire from the microphone. I want to make a date with you. I want to see all of you here in 2022 for the 3rd Riyadh International Humanitarian Forum. Thank you so much and enjoy your day. Thank you.